And so that's the ability of our human body to bounce back. And one of the reasons why older adults have so much trouble with COVID, and why 20% of all the deaths per COVID are in the 85 and older age group, is because of their inability to bounce back biologically or physiologically. And so from a geriatrics point of view, we always look for small things that we could do to help build that biologic resiliency. And sometimes they're just small things like, looking at their vitamin D levels. I mean, when in our geriatric clinic, we're constantly looking at vitamin D levels. And I'd say half the patients have suboptimal vitamin D levels. And we know that there is some evidence that higher vitamin D levels are a way to protect yourself from severe COVID, as an example. So again, both in terms of the emotional, psychosocial view, and then also the biologic view of resilience.
Thank you, Dr. Jurevich. Yeah, I'm Jean Rowland from Quality Health Associates of North Dakota. We're North Dakota's health. We mentioned last week that we're going to walk through the 12 steps of QAPI in this series. Those steps are outlined in QAPI. This week, Natasha Green spoke to step 1, leadership, responsibility, and accountability. In her presentation, she highlighted the importance of active leadership engagement in QAPI and their allocation of resources for QAPI, both that are crucial for QAPI success. She also discussed walking rounds and provided suggestions for making. As a result of last week's walking rounds presentation, what one thing did you identify that you will change in your current walk? And says, I make sure that I am rounding on all of the teams and involving the whole team. Need for others to be aware of concerns. That's great. That's great. Important to dialogue with the staff that you're when you're conducting rounds, and not make it a checklist type. Leaders, including those who don't have formal authority, consciously encourage and model teamwork and good communication. So I'm going to cover QAPI step 2, develop a deliberate approach to teamwork. And what does this mean, and what does it look like? The Institute for Healthcare Improvement defines teams as a group of people that work together in a coordinated way, maximizing each team member's strengths to achieve a common goal. IHI then goes on to say that a strong and effective team can anticipate mistakes, overcome obstacles, and navigate difficult situations. So, in other words, have resiliency. This is exactly what we want to see in our QAPI teams. So when you stop and think about it, being a member of a QAPI team is really no different than being on any other team that you've been on in your life. Maybe you've been a part of a formal club. Maybe you've participated in sports, or you can even consider your family unit a team. Regardless of the team, the commonality these teams have is that when team members work together, communicate effectively, and value one another's input and expertise, the outcomes are bound to be good. Next slide, please. So teamwork is a core component of QAPI that can be taken for granted, and all too often is. Therefore, developing a highly effective team needs to be a very deliberate thing. QAPI at a glance notes that effective teams have a clear purpose, defined roles, and active engagement. So we're just going to talk about each of those. Next slide, please. Excuse me. Every team should have a clear purpose. A PIP team will have an assigned issue to address. That's just part of the process. But QAPI at a glance recommends a charter for every PIP developed. The PIP charter will help you define the team's purpose and set goals. Charters really serve as an added strength. They provide the strength, importance, structure, and formality in the PIP process. And we're going to focus more on the charters during session 9, but I just wanted to highlight how they impact defining purpose. Next slide, please. Every team should have defined roles for each team member to play. For example, the roles of team members may be defined by their original discipline or their job responsibilities. A provider or a nurse, for instance, may bring clinical expertise to the team. A physical therapist will be especially valuable if your issue at hand is mobility. I'm often asked, how many people should be on a team? Your team should be comprised of at least 3 people at a minimum. but more is better. And you're going to hear that again. More is better, especially when you're conducting root cause analysis. So with regard to nursing homes where individuals often wear multiple hats, I would recommend people on your team to fill 3 key team roles. But remember, more is better. What are those key roles? One is someone in a decision-making capacity. This person will be able to give the team authority to move forward with their functions and will be the person who carries information back to leadership about the progress of the PIP team. When I think about this, I think it would likely be a DON or an assistant director of nursing or someone else in a leadership position. The other key role is someone close to the PIP issue. So if the issue at hand is related to medication management, you benefit by having a pharmacist or a nurse or a medication aide on board. If the issue at hand is staffing, you probably benefit from having an HR person or someone from the business office involved. If the issue at hand is resident care related, you may want to include a staff nurse or a CNA. And it would be just great to have both, but the value of CNAs and PIP as PIP members cannot be overemphasized, okay? CNAs generally have more one-on-one with residents than any other disciplines in the nursing home, and their definite asset I provided clearly highlight the value of interdisciplinary teams. The third key role is someone to conduct the team's day-to-day functions. So this person would probably take responsibility for preparing agendas, facilitating the meeting, keeping minutes, organizing communications, maybe organizing data collection. When I think of this role, I think of the QAPI manager, or maybe someone that the QAPI manager delegates to. Next slide, please. Effective teams need commitment to active engagement from each other. It would be remiss of me if I didn't at this point emphasize here the importance of frequent, clear communication to facilitate team engagement and to move the team toward their goal. We're going to talk more about communication a little bit later. Next slide, please. Teams can take on many forms, and QAPI relies on teamwork in several ways. So you may have a task-oriented team that's formed to investigate a specific problem. That's been a hard word today, but their work is limited and focused. PIP teams, which is the focus of our meeting today, are formed for longer term work on an issue. But regardless of the team, interdisciplinary teams are a must. So when it comes to chartering a PIP, carefully consider the purpose of the PIP and the type of members needed to achieve that purpose. I've always said that it's sometimes the least obvious discipline that has the biggest impact on your team. Family members and patients may be team members, but there is something that you have to consider here, and that is confidentiality. They may not be able to review certain data or information because of it identifies individuals. So you'll need to be careful there, but regardless, the perspective of family members and residents, is absolutely valuable to the team. Effective teams communicate openly and often. PIP teams need to plan from the onset for sufficient communicating, and that includes face-to-face meetings where they get to know one another. But communication doesn't stop when the meeting ends. The team should plan on how each team member will receive and review information that emerges from the PIP in between meetings. For instance, will the information be emailed to individuals? Will it be placed in a work mailbox? Will individuals be notified by text that there's updated information for them to look at? I think in this electronic age, the options for communication are very broad. But regardless of the communication plan, every team member has to be accessible. They have to make themselves accessible and feel confident that their suggestions will be heard and acknowledged. And I think this is probably a good time to note that a critical element of psychological safety is respect. So when team members feel that their suggestions or their input might be criticized, a very unhealthy dynamic occurs and it erodes the team. So simply treating fellow members with respect, talking to them, listening to them, providing constructive feedback is the first step toward effective communication and creating a high functioning team. Leadership also needs to convey that being on a PIP team is an important part of the job. It's just not something that you can put aside. It's not something extra to do. It's part of what you do. So last week, Natasha talked about leadership and the need to support QAPI by allocating time and resources. This includes seeing to it that team members have the time and resources to complete their daily assignments, to provide the resident care that they're there to provide, and then to be able to participate on the QAPI. To the second session of our QAPI piece here today, and Liz Letness, Chief Clinical Officer with SMP Health, which is our North Dakota's mentor nursing home, is going to provide a practical application of QAPI guidance in her day-to-day work. So Liz, I'm going to let you take it from here.
Thanks, Jean.
Mm-hmm.
So I'm actually at SMP Health St. Catherine North and South in Fargo here. And so we've used some PIP teams over the last few years since the initiation of QAPI. And so some of the things I'm going to talk about kind of fit right in with what Jean has just talked about. So our PIP groups have really helped us be successful in some of our bringing some of our quality information, our quality measures down into a better level for us and helping us with problem solving. So I'm going to focus specifically on falls. So you can advance to the next slide. So when we were choosing our team, so we looked at having an interdisciplinary team. So nursing, of course, with falls is a big part of that, but also we looked at care management, CNAs, activities. We included the DON was a part of the team for the decision making, as well as our quality nurse, which Allison was our quality nurse at the time, is now our DON, and she's on the call as well. And so we included all of those people for specific reasons in looking at falls. So we wanted to make sure that it was collaborative, so we didn't leave out any departments that could be helpful in looking at how we can prevent falls and also how we can prevent injuries for residents, because that's another area, as we all know, that goes right along with the falls. So we also wanted to establish that everybody's voice was just as important. So not that one of us takes precedent over the other. We want it to be really collaborative and talk through ideas to come up with some different areas to focus on. We all had the common goal of decreasing falls and preventing injuries. So that was an easy part of our process, but we then developed more specific goals, not just to decrease falls is kind of huge. So we focused down on some different areas and then formed kind of mini groups to talk about those things. And I'll look at that in just a minute. And then the other part of it, I think that really became important, and maybe with COVID and, looking at teams being resilient, COVID kind of was a blip for everybody. So we really had to, try to say we have to dedicate time to meet. So there's 100 other things that come into our days, but we had to dedicate that time to set a meeting and really focus in, because we could put it off forever and not get to it, but that wasn't our purpose. So the slide, I kind of let you know, being creative, an effective team. We try to be innovative, and as Jean had said earlier, communicative is huge. So communicating within our meetings, but also outside of what we're seeing and what we can try different to accomplish our goals. So next slide. So actually the characteristics of an effective team is right out of the QAPI at a Glance book or the handout that Jean referenced earlier as well. And so that was, we used that QAPI at a Glance as kind of our Bible to start with, because we were really new to forming a PIP team and what the heck do we do to get this going. So we really use that resource as our starting point to get our group together and set our goals and start moving on how we can get some work done. So, our overall goals, we looked at our goals for the team, as I just said, and then we defined roles and responsibilities. We knew we had to have a team leader that would call the meetings, make sure that we had the meetings scheduled and ready. We wanted somebody that was going to record what we were talking about and where we were going. And I think the decision maker piece was really important too, to have that person on the group. So we made sure that we kind of defined who was going to do those things for our falls team, and then kind of went forward from there. The clear communication, again, everybody's voice was important. So we found some really interesting things, and that, such as, how do activities play into falls? How do maybe meal times, sleep? Those are kind of really interdisciplinary things that we looked at. And again, kind of talking about prioritizing the work. We kind of started out, and then discussed what our mini goals were kind of along the way. And I think that was really important, because when we started just looking at, falls, that was huge and it's hard to wrap your mind around. So that's where we had to kind of focus down on activities, or looking at our falls tracker that we use. What's our highest fall time? And we found that it was in the evening from 5 to 8 p.m. We focused down on that specific time. How can we make an impact on that time of day, and what's going on for the residents during that time? So that's where we kind of looked at forming some smaller goals and smaller teams to look at that. So next slide. That's what the CWOPI at a glance booklet looks like. And like I said, that kind of became our Bible. So definitely look that up if you're looking to get started with your PIP team, or even I've referred back to it, just like, how do we keep going? What can we, how can we get the teams focused on our goal, or how can we re-engage the team to keep going when we aren't really sure where we're going right now? So that was good. So here's the two areas that we quickly identified: the evening routine and bedtime. So we found that activities right after dinner were done by 5:30 at night, and then residents were going up to their unit, and they're going in their room, and pretty soon they're like, well, I don't have anything else I want to do right now. I want to go to bed. So people going to bed at 5:30, then they're awake during the night and they're getting out of bed. And we, really wanted to kind of look at how can we keep people active later in the day. We know they're not going to stay up till midnight, but can we keep residents more active till maybe 7, 8 o'clock, so that they can have maybe a snack before they go to bed, and kind of take care of hunger, toileting, getting ready for bed, having a routine, kind of looking at all of those things. And most of us have less staff during the nighttime. And so if we have residents that are waking up and wanting to be up, there aren't as many staff to attend to them during the middle of the night. And so then people try to get up themselves and maybe have falls during the night if we're not keeping them busy. So we kind of created the habit for residents of wanting to go to bed earlier, and because they didn't have things to occupy their time. And so instead of just sitting, watching TV, they decided, I might as well crawl into bed. So looking at that. And I think the big thing that we found was it was challenge the nursing staff to change their routine, because it's kind of like we're all, a lot of us nursing staff, we're task oriented. So, it's like, let's get people to bed because that's our next task of the day. So we did challenge them to make some changes there. And it's still a work in progress, for sure. We also challenged activities to look at maybe some different activities, or can they have activities available to do later at night when there aren't activities staff necessarily up on the floor to do, activities that are planned and for a group of people. So that was kind of a challenge too. So the other thing we kind of looked at, for the activity piece of it, most of our activities are during the day. So, and a lot of the same residents attend. So if they don't like those activities, or if say a resident maybe that doesn't like bingo, well, if we have bingo, are there other things that we can plan for them to do? So again, looking at the different times of day where we had falls, that was one of the things we really looked at, and then trying to incorporate different activities, some for low cog residents that maybe can't play bingo without somebody helping them. So trying to just incorporate some different activities as well. And getting residents out of their room, getting them more active. We involved therapy to also look at, if they have weakness or balance problems, can we help strengthen them? So we kind of, circled around through strengthening and as an activity as well, trying to do some physical activity. So we kind of incorporated a lot. Some of the approaches we used for our team were audits. We maybe did some audits of how many people are in bed at 7 o'clock. What can we do during those times? What kind of activities do people like? We did observations. We had some of our leadership team do walkthroughs throughout the building at 6, 7 o'clock at night to see what's going on the floors. Can we get an idea of what different things we can do? We interviewed staff and residents. We use Pinnacle surveys to also get some ideas of what, the likes and dislikes of our residents and their families. So we use that information. We did some face-to-face meetings to talk about what we found. And then, like I said, challenged the different departments to kind of come up with some different ideas. We did pilot changes on one unit or floor. So we tried implementing activities where a nursing staff, an RA or a CNA did some small activities on the floor while other staff were helping the residents maybe get ready for bed, and did that, it actually went over really well. And so they found that for the CNAs, they loved doing that activity. It was a different thing for them than just doing all the physical cares. They got to actually visit with residents and talk to them and do some different things. We actually had a resident that would do some readings for the other residents, so just looking at different ideas. And we tried that on one floor and then brought it to the other floors. So we did use the plan, do study act, the PDSA cycles. So I think we've probably, if we've been working with CWAPI, we've used those a lot, but we tried to put it into those, what were results, what changes can we make, and just continuing to look at that to come up with some problem solving. I thought this quote was really good. Individual commitment to a group effort. That is what makes a team work, a company work, a society work, a civilization work. And I think that's, our commitment to the PIP teams really has made it successful. And I think teamwork, everybody kind of being a part of that team has helped us we've actually gotten, so we are not triggering for falls any longer in our facility, and we are in the 90s pretty consistently for falls. So I think we have seen some positive improvement